Welcome to Session 4 of the PneuBack Program Level 1. In this session, we will be reviewing the vest, the thigh cuffs, and the gait straps. Make sure that you have had an opportunity to review and fully understand the material in the manual, and that you have the manual available on hand as we go through this webinar. When we're putting on the vest, there are a couple of things, very important things to remember. Primarily, the vest is designed as a way of being able to do traction off of the lower back. And in order to do this, the vest needs to be put on relatively snug. Please keep in mind that the contraindications for utilizing any unweighting equipment include, one, keeping an eye on any patients with respiratory disorders, and that would include when utilizing a vest, as this compresses along the rib cage. And secondly, we want to make sure that with any type of traction that a patient does not have any forms of spinal tumors or anything that may be exacerbated when traction is started. When selecting a vest for the patient, the number one thing we want to make sure is that the patient is wearing appropriate clothing. Primarily, if we're looking at patients who come in with bulky, loose-fitting clothing or clothing that is relatively slick, then we want to make sure that the vest does not slide up on these patients. So bulky and loose-fitting clothing may have to be removed at that point in time. The vest sizes are dependent primarily on the waist sizes, and roughly the red is the small, blue is medium, which will fit most average adults, and yellow vests are for larger adults. There is a pediatric vest for children, as well as an extra large vest for adults who do not fit into the yellow vest itself. When putting on the vest, what we're providing you here is some of the recommendations that we see. Obviously, there will be different ways of putting on the vest, but this is one of the easiest ways that we have seen. Utilizing the unweighting system, we can attach the vest to the spreader bar to hold the vest up, and as a result, the patient is able to put it on much like they would put on a jacket or a coat. Have the patient start by facing towards the back of the treadmill, or excuse me, facing away from the treadmill, and have them put on the vest just like a coat. One arm goes through one side, the other arm goes through the other side. When positioning the vest, it's important to make sure that the bottom of the vest is just below the ASIS. This is important because when we start to snug the vest down, it will place it in the abdominal region such that it will grab right underneath the rib cage and be able to use that as a positioning and a pull point. This will also minimize the riding up of the vest such that it does not catch up and underneath the armpits itself. When pulling in the elastic tensioners, put one side over the other and making sure that the Velcro is there. In the pictures, you see the patient putting the vest on. In most cases, the assistant or the clinician is doing this for the patient. When they're doing this, sometimes we do recommend asking the patient to hold on to either side of the legs of the unweighting system. That way they can stabilize themselves. We always recommend that you attach the vest as snugly as possible to prevent it from riding or moving around on the patient as they start walking or doing their exercises on the unweighted treadmill. After you have the vest placed snugly, you can utilize the ischial tuberosity or buttock strap, which is designed to ride underneath the ischial tuberosity and keep the vest from sliding up any further. The ischial tuberosity strap simply clicks to one side at the bottom front of the vest, runs around along the hip and underneath the ischial tuberosity, and snaps into the other side. There are two straps that can be pulled snugly on the ischial tuberosity strap, again to make sure that it will catch in the right area. If you have a patient that has not very pronounced ischial tuberosity, then you can utilize a jaw strap, which will then require you to put on the thigh cuffs and run the jaw strap from the sides of the vest down through to the thigh cuff and then Velcro to the thigh cuff. There are different vests that are utilized for the NUMEX protocols. Primarily, the two that you will be most familiar with are the sports vest and the vector vest. The sports vests have no adjustments on the back and are primarily used for athletic and performance training. The vectors vests are utilized for rehabilitation and gait training. So if you start to see any patient that you will need to correct things like varum valgus, internal external rotations, those types of problems, a vector vest will be the most will be the piece of equipment that you'll want to utilize. You can tell the vectors vest because it will have straps and buckles along the back of the vest itself, not just along the bottom. So there are different scenarios that the vectors vest can be utilized for. If we're looking at patients who have different problems with their lordosis, whether it's normal, whether it's too much, whether it's too little, along with patients who may have a posterior SI, patients with functional leg length differences, the vectors vest can be utilized to help make corrections while the patient is active and doing exercises. Primarily, we will evaluate the patient based off of not only our initial evaluation, but also from doing a gait strap, which will be covered in a separate session. But also importantly, we will utilize the new map that we started off with in step 1. If you have not performed a new map up to this point in time, it is highly important that you do so at this point in time, as the new map is the only way to adequately determine whether a patient has a true hyperlordosis or hypolordosis. What we will be doing then is we'll be reviewing some of the uses of the vectors vest, and we'll start off by reviewing a patient who has different lordosis amounts within their back. So suppose you see a patient who has a has a normal lordosis as shown off of the new map. In this case, what you would do then is that you would take the two straps along the back of the vectors vest and you will cross them over so that they clip to the opposite middle clips along the vest itself. So when we're looking at a vest, there will be 3 clips. There's one in the middle, there's one in the bottom, and just outside this picture, there's one on top that you can actually see here. So you can see the top, you can see the middle, and you can see the lower on the picture below here. So when we're dealing with a patient with a normal lordosis, we will take the strap from the one side, run it to the opposite middle strap, and clip it into here, and take the strap from the other side, run it to the opposite strap, and clip it into the middle. When it is placed in the middle position and the traction occurs, it does not accentuate or reduce the amount of lordosis within the curvature, and the patient will hold the lordosis that they normally have. Ensure that once you've clipped the clips into the patient that you're able to pull these straps nice and snug along the patient. No pain should be noted. If you're dealing with a patient who has less lumbar lordosis or hyperlordosis than you normally would expect to see, and this shows up on the new map, the way to utilize the vectors vest to correct this then is to take the strap from one side, run it to the bottom clip on the opposite side. Same thing, take the strap on the other side, run it to the bottom clip on the opposite side. So we will always cross over, as this will give us the maximal effect. Once this is done, remember to tighten these straps so that they're nice and snug along the patient, so that when the traction is pulled up on the patient, then what the vest will actually do is that it will pull this way and it will pull this way and cause more of a lumbar lordosis on the patient's lower back. Again, ensure that there is no pain or discomfort for the patient when the traction is being put on the patient. When utilizing the vectors vest in a patient with hyperlordosis or more lumbar lordosis than normal, based off of the new map, the way that we would correct for this then is, again, we would take the strap on one side, run it to the opposite clip, however this time on the very top. Same thing, the strap on the other side to the opposite clip on the very top. Pull the straps nice and snug so that when the traction occurs, then what this will do is that it will traction from here upwards and reduce the amount of lordosis down into the lower back. Ensure that there's no pain or discomfort on the patient as this is being set up and while the traction is being run. If you have a patient who has a left SI that has gone posterior, So the left SI is coming out towards us, and the right SI is going forward, then we can correct for this by utilizing the vectors vest in such a way that we would take the strap on the right side and go down to the very bottom clip on the left side, and take the strap on the left side to the very top clip on the right. By doing this, then, once the traction occurs, the force is going to be put just down along here, and it's going to pull up this way and rock that left SI forward. Ensure then that the straps are tightened and that there's no pain or discomfort on the patient while they're utilizing this correction. The opposite would be true then if you see a patient with a right SI that's gone posterior, so this right ilium is rocking backwards, or the left ilium has rocked forwards. In this scenario, then we would take the left strap and clip it to the right bottom clip, and take the right strap and clip it to the left top clip. When the traction begins in this scenario, then the force will run up along the strap here and rock this ilium forwards. Again, make sure that there's no pain or discomfort on the patient as you go through this work. Final note, when utilizing the vectors vest, please ensure that for each time you see the patient that the straps are properly adjusted. Do not take a patient and just because the clips are in the right position, you do not tighten the straps. The tightness of the straps will be important not only in keeping the vest from riding up, but in also ensuring that we get the maximal correct forces that the patient will need to have for the correction to occur. When we see a patient now who has gait problems, whether they have external rotation, internal rotation, there are two things that we can do to work on those types of patients. Primarily, we will start from the hip down, meaning that if we see a patient with external rotation, we will begin by utilizing thigh cuffs before utilizing gait straps. However, in most cases, a combination of both is the most effective. The utilization of the thigh cuffs are relatively important, as the positioning of the thigh cuff can help to keep patients from toeing out, toeing in, having genu varus or valgum problems at the knees. It can also help with patients who tend to overstride or take bigger steps on one side and smaller steps on the other. When we're setting up for a patient with external rotation, the basic setups for the unit are the same. We will still utilize the vest as we did in the last step. And you will notice that at the bottom of the vest there are actually different clips that will run along the bottom edge of the vest. There will be ones on the inside and there will be one out along the outside as well. When we're doing internal and external rotation correction, we always utilize the most medial clips along the back of the patient. The other thing we will utilize the thigh cuffs themselves. You notice that if you have a thigh cuff available to look at, the bottom edge of a thigh cuff is always completely straight and flat. The top edge will have an oblique section, it will slope upwards, and then it will go flat. This is important to differentiate, as that cut that with the slope upwards allows for movement and reduces any type of chafing or restriction on the patient as they move. When a thigh cuff is placed on, you'll also notice that there is a color band that runs along the thigh cuff, along the face of the thigh cuff itself. In this picture, you can see that color band is facing posteriorly. However, what we have recently found and recommend to all clinicians is to face the color band along the outside strap of the patient's thigh when putting this thigh cuff on. The thigh cuff should ideally be placed roughly above the kneecap to the middle of the thigh, as we find that the lower down you can put it away from the insertion of the femoral head, the more correction we have a longer lever and the more correction we can make. So when placing the thigh cuff on the patient, remember to keep the color band along the lateral side, which is a little bit different from what the picture shows here. And remember, your top edge is the one that is slightly sloped and profiled. As we put on the thigh cuff, ensure that it is relatively snug. In fact, the snugger you can place it, the better it will be, as it will be able to grab onto the thigh and make the correction that we need to make. When doing the external rotation portion then of the correction, we want to take one strap, clip it into the most medial position on the vest, and run it down in between the inner thigh and around the front and outside of the thigh cuff. Prior to doing this, though, it's going to be extremely important that we mirror image what the patient is presenting with. So in this case, if they're walking with their feet point and their toes pointing outwards, we're going to ask them to turn their toes as far inwards as we go ahead and run the strap between the inner thigh around the front and velcroing it to the thigh cuff itself. We want to pull this as hard as possible, as this is going to be the correction for the patient. No pain or discomfort should be felt. Now in this picture, you can see that there are actually two bands that are being used. However, each leg needs to be evaluated independently when we do our gait evaluation. So you can have a combination where a patient may have one foot externally rotated, the other one pointed straight forward, or you can have both externally rotated, or you may have one externally rotated and one internally rotated. So it's important then to make sure that we evaluate both sides. Remember, some of the key components to this is that the thigh cuff needs to be relatively snug. It needs to be as snug as you can without causing any pain or discomfort. The location of the thigh cuff needs to be roughly above the knee, or at least lower down along the femur itself. When utilizing the straps, you want to use the most inside connection point running down in between the thigh along the front and strapping into the back half of the thigh cuff itself. Have the patient pre-position themselves such then that their toes are already pointed inwards, and pull the strap as tight as you can without causing pain or discomfort on the patient. When doing the internal rotation, we're seeing a patient then who, as they walk on the treadmill, their toes point inwards towards each other. Again, the same basic principles are the same. We want to make sure that the thigh cuff is put on correctly at the right level, and we want to utilize the strap such that the strap is now again on the most medial clip up on the vest itself. Ask the patient to turn their toes as far out as they can, doing one side at a time. If you need to strap both sides, ask them to turn their thigh as far out as they can while their knees are relatively straight, and go ahead and pull the strap now down and around from the back to the front and velcroing to the inside of the thigh cuff itself. Remember to pull as hard as you can without causing any pain or discomfort to the patient. When dealing with a varus or a valgus condition, the main difference that you're going to notice here then is that you got to make sure that these thigh cuffs are down just above the knee. The area where we want to affect is going to be the knee. The other main difference that we want to keep in mind then with this is that instead of using the most medial clip, we should be using the most lateral clip on the vest itself. So do not be confused by the picture. This is actually supposed to be the most lateral clip up on the vest. When we're pulling this through, it is it's going to be similar then to the procedure we used with the external rotation, except now the patient will not turn their toe inwards. They will keep their feet pointed straight forwards. More importantly, we want to make sure that they have their knees pointed straight directly ahead. In some cases, you'll actually see that the knee is rotated. In a lot of genu varus, the knee tends to be pointing outwards so we want to make sure that the knee is pointing back inwards before we do our correction. And simply what we'll do then is we'll run the strap along the inner thigh through the front, wrapping around the side and out to the back here. And again, we want to pull as tightly as possible on this when we're strapping. We can utilize the other side if necessary, same procedure. On the genu valgus, we're looking at the same issues here now then. We want to use the most lateral clip. So if there is a clip in here, we'll use the most lateral one available on the vectors or on the vest itself. And what we will do is make sure that the thigh cuff is down so that just above the knee itself. In this case, make sure that the feet are pointing straight forward, or more importantly, make sure that the knees are pointing straight ahead. So in some cases, you will see that by pointing the knee straight ahead, it may cause the feet to change positions a little bit. We can correct for that when using the gait straps. But when doing the varus and valgus, make sure that the knees are pointing straight ahead. At this point in time, then we will clip the strap, run it down, pulling it as hard as possible, such that we're running along the side, wrapping to the front, and then back to the inside of the thigh here, and velcroing along the thigh cuff itself. Make sure that there's no pain or discomfort on the patient as you have this and while they are unweighted and walking. In a patient who is overstriding, what we will simply do then is we will go back to finding the clip that is directly in line with the middle of the thigh itself. Ask the patient to keep their knees pointed straight ahead and clip the strap down and through the thigh cuff, coming back and velcroing either to the vest itself or velcroing to the strap. The tension on this belt then will keep it that as the patient is walking, it will keep them from taking the big strides on the affected side. So remember, keep in mind that as we look at the overall for utilizing the thigh cuffs themselves, that the most important things to keep in mind are the positions and the positioning of the thigh cuff. Primarily, we want to have the thigh cuff to be snug because it is an anchor and a pulling point. In most cases, you can either cuff along the medial of the medial area of the thigh, or bring it so that it is above the knee, as close to above the knee without causing any type of restriction on walking. When we are utilizing it for internal and external rotation, we will use the inside clip and we will run the strap down as snug as possible with the patient positioned to what correction we want to do. And in general, the correction will always be mirror imaging to the problem that the patient has. When we're utilizing the gait corrections then for our patients with genu valgum or varus and the problem is directly at the knee itself, again, we want to make sure that the thigh cuff is snug on the patient and that it is as close to above the knee as possible without causing restriction. In this case, we do not need to position the patient, but what we will need to do is make sure that the knee itself is pointing straight ahead. Do not be overly concerned if there are any type of toeing in or toeing out as you position the knee itself, because that can be corrected by using the gait straps. When we do the genu varus and valgum, then with the knee pointed straight ahead, we will use that outside clip and run the strap in the appropriate position, again pulling it as tight as possible without causing pain or discomfort on the patient. Remember to keep in mind that many patients have more than one problem, so we will address the most obvious problems that stick out when we're doing the gait evaluation. So for example, if you have a patient who has a genu valgum as well as an external rotation, we want to focus on the one first that is causing the most obvious problem that the patient presents with. Once that has been corrected, then we can go and work on the other one. Also keep in mind that patients are not necessarily symmetrical, so a patient who may externally rotate on one side can still internally rotate on the other, and vice versa. When we're looking at doing the gait corrections, particularly with the foot straps, there has been in the past some confusion as to how to identify and what it is in particular that we're talking about when identifying gait problems. When we're looking at, in this case, a patient who has a lateral outside heel strike and a medial inside push-off, the thing to keep in mind then as you're watching your patient walking is to think of this patient as when they're doing their heel strike transitioning into mid-stance, they're staying on a lateral outside position during mid-stance. This, in general, is defined as being over-supinated at mid-stance. So this is what we'll be discussing in this in this portion of the webinar. So when we are dealing with a patient who tends to over-supinate at mid-stance, there is a correction that can be used for that, and that comes in the form of utilizing the foot straps. The foot straps are, for those of you who are familiar with them, primarily composed of two components. One is a cuff that needs to be placed right at the ankle. The other one is the strap itself, which is composed of one nylon strap with a Velcro component, and then there's another ring underneath that looks like nylon strings, and then there are two long Velcro straps that are attached to it. When we place the ankle strap around the patient, it is very important that it be snug. Because of the Velcro itself, some patients may feel that it is uncomfortable, so we typically recommend that every patient who wears the gait straps be wearing at least some socks. Those patients who wear the ankle socks, those are almost too low, so we recommend that they wear the socks underneath the gait strap, and that the gait strap then, or the ankle strap itself, be tightened as snugly as possible. When we put on the other component of the foot strap itself, then the two parts that look like two nylon strings will go underneath at the sole of the shoe, and the other Velcro component then will go along the top. Positioning of this then is that we want the foot straps to be closer to the toes. Primarily, we want it to be just in front of the widest part of the foot itself. So it will be roughly at the base of the metatarsals. Once we have this, again, this will need to be Velcroed relatively snug, and this will be Velcroed relatively snug. When we're dealing with patients then, and we're utilizing the foot straps, we will always do some dorsiflexion on the patient. That is what we will always want to do then with these patients, is we will need to take the foot part and bend it up so that the foot and the ankle, so that the toes are pointing up towards the patient's head. If you have a patient who is standing with their knees locked or their knees straight, this can be difficult to accomplish. So we recommend either having a small footstool that the patient can bend their knees so that you can bring the ankle upwards, or at least keep them from locking out the knee. Because if you lock out the knee, then what's going to happen is you're going to get a lot of stretching along the calf muscles that will prevent you from getting a maximal amount of dorsiflexion. As we prepare for doing the patient with oversupination, as in this case where they land on the lateral or outside portion during heel strike, and particularly at mid-stance, what we will do then is we start off by bringing the patient into maximal dorsiflexion, so bringing this ankle so that the toes are pointing way up in towards the patient's head, and we will assist to bring them up as much as possible. At this point in time, then we will take the outside strap, and we will pull the strap as hard as possible. So we'll take this outside strap, pull it as hard as possible up and across, and strap it to Velcro it to the ankle cuff itself. We will then take the opposite strap, the inside strap, and just lightly strap it to the outside. This one does not need to be anywhere as tight as possible. So this one is just a stabilizer strap. It's not the effective strap. But remember, we will always bring it up and across, so we always cross the foot and the ankle itself. Ensure that the patient does not feel any pain or discomfort when this is placed on them, as it will be utilized for the gait correction. When we're doing a medial inside heel strike with a lateral outside or medial push-off, again, what we're looking at then is that as they do their heel strike on the medial and they roll into mid-stance, at mid-stance the patient will still be medial on the foot. This essentially will be a description of a patient who overpronates. When we're placing the ankle strap, then the ankle strap needs to be, again, as snug as possible, and we do recommend that the patient wear socks. The foot strap itself, the second portion, will be placed at the foot just anterior to the widest part of the foot, roughly along the base of the metatarsal itself. And then what we would do then is we would Velcro that nice and snug, and we would pull take the patient then with their knee bent to about 90 degrees, and we will take this ankle and we will maximally dorsiflex. So we will bring the foot up, and as we maximally dorsiflex, we will turn them into the opposite position. So it will be almost like, since they tend to over pronate, we'll bring them into supination. And we will go into maximal dorsiflexion and supination, or in some cases people will define this as an inversion type maneuver, where where the sole of the feet will be turned inwards. And we will pull as hard as we can on the medial strap and Velcro it to the outside of the ankle cuff. The opposite strap, then the outside strap, will be pulled up to the inside of the ankle cuff. However, it does not need to be pulled very hard, as it is nothing more than a stabilizer at that point in time. When dealing with a patient who has toe drag, external rotated lateral heel, or a medial push-off, we're primarily looking then at patients with a foot slap, so they're unable to keep their toes up. This procedure can also be utilized on patients who have problems with shin splints as well. In this case, we would add a second ankle strap to the patient here then. So then we have our first ankle strap right here. Then we will put a second cuff right on top of it. What this will do is that this will increase the pull point, give us a longer fulcrum to pull from. Again, we want to make sure that the knee is bent roughly to 90 degrees so that we don't get the pulling along the calf muscle. And what we would take this patient into is we'll bring them into a maximal dorsiflexion without inversion or eversion, and cross the straps over as we see here and pull both of them as hard as we can, keeping the patient in maximal dorsiflexion, and then Velcro the straps to the top ankle cuff itself. Patients should feel no pain or discomfort. In fact, for patients, especially the ones with shin splints, will actually tell you that it feels better for them to be utilizing the foot strap in this position. Some of the more important things to remember is that we utilize the ankle straps as well as the thigh cuffs because they help us to re-educate the muscles and to change the amount of muscle memory. We found that this needs to continue not only within the clinic itself, but also outside of the clinic. So when we see patients at our clinic, we recommend for them that they purchase a set of foot straps to utilize at home. Essentially what we would do then is, after our first visit with the client or the patient, we will put the foot strap, instruct them on how to utilize it for their particular problem, and ask them to keep it on for 1 hour that first day. After the first day, then they will work up to, within a week or about 7 days, to 4 hours of usage every day. After that point in time, the patient is told that they will need to utilize the gait straps every day for about 4 hours during their busiest time, meaning during the time that they're actually up and on their feet and walking around. The 4 hours do not need to be consecutive and can be broken out during the day. However, it does need to be utilized when the patient is walking and moving, as it will correct and change the amount of muscle memory in terms of when the muscle fires and you set a new position, the muscle will learn that new position. We recommend this for about 3 weeks of usage, after which point in time the patient will not need to utilize it as much. Again, what we have seen is that if the patient is unable to comply with the 4 hours a day for the 3 weeks, it just takes longer for the muscle memory to occur. After the 3 weeks time period, there does not seem to be a necessity for continual usage, as that seems to be sufficient then for the patient to be able to hold the memory and to hold the position that we need. Periodically, however, the patient may need to utilize the gait straps once again to reinforce the new position. Final notes to keep in mind when we're dealing with the vectors vest, when we're dealing with the thigh cuffs, when we're dealing with the foot straps, is that each of these pieces help to accommodate a change, and each of these pieces should be utilized in conjunction with one another at every visit that we see the patient. remember, if it is appropriate to utilize these pieces, then it must be utilized when they come in to see you, because every time they're doing the exercise or the work, a small correction is made. If the patient complies with your instructions to utilize the home gait straps themselves, then the patient will continue that process of correction outside of the clinic and outside of when they see you. However, it is not practical to have a patient to utilize something like a thigh cuff or a vector's vest when they're not in the clinic. So those components need to be utilized each time, along with the gait straps every time that you see them in clinic. It's also important that we take the time to watch the patients as they are walking on the treadmill. So doing a good gait evaluation at the start is crucial. Keeping up with our map is crucial in knowing whether they're hyper or hypolordotic, and keeping an eye on the patient as they go through their exercises is important, because we will also start to see corrections and changes through the weeks as they go through the work with us. So for example, with the gait straps, roughly about 4 weeks is where we will know that the patient will be able to hold a correction. So at that point in time, it may be important for us to go back and reevaluate the gait to ensure that everything is where we need it to be, and that any type of corrections or changes to what we've been doing may need to be done at that point in time. Thank you for joining us for this section of the webinar and this session of the back program level 1. Please ensure that, again, if you have any questions or concerns regarding any material that was talked about in this webinar or in the manual, feel free to contact us and we will be available to answer your questions at any point in time. Again, thank you for your time, and we will look forward to seeing you on our next webinar series.